السلام عليكم طلاب. Our lecture today is about tumors of the vulva. These are some important benign vulval lumps. We will discuss the most important and commonest type, which is the Bartholin cyst. Other benign lesions including epidermoid or epidermal inclusion cyst, Skinny's duct, congenital mucus cyst, cyst of the canal of Nook, sebaceous cyst, papilloma, and fibroid all are other types of benign vulval lumps, but we have to concern about the most popular type اللي هو البناين cystic اللي نسميه البارتولين cyst. benign cystic tumor البارتholin cysts are the most common type of such a cystic tumor, and Bartholin abscess can occur when one of the Bartholin's gland located on either side of the vaginal opening. When it becomes infected, it will lead to Bartholin abscess. Bartholin cysts usually appear as a painless lump next to the vagina, while Bartholin abscess associated with lump and tenderness and hotness. The Bartholin abscess can be more than an inch in diameter. It is usually causes significant pain, while most people with Bartholin abscess completely recover. In some cases, the cyst will return and become infected again. If an abscess develops, the lump will be painful, typically distending the lower medial third of the labia majora and minora over it, with tenderness, congestion in the area, and pus discharge in some cases. Treatment include draining the cyst followed with antibiotic, and sometimes we have to do marsupialization. What we mean by marsupialization is opening of the cyst and draining of the abscess and maintain the mucous membrane in continuity with the skin by suturing the edge of the cyst to the surrounding skin. This prevent reblocking the cyst. This picture shows the site of Bartholin cyst, and this picture shows marsupialization. You can see that we are opening the cyst and draining it and then suturing of the edges to the surrounding skin to prevent reblocking. We have other type of benign solid tumor اللي هو commonest type. It is called genital wart. وزملائي الأساتذة أعطوكم sexual transmitted disease ومن ضمن ال STD type هو الجينيتال وارت، فما راح أعيده مرة ثانية. عندكم الفولفال intraepithelial neoplasia. This is a pre-malignant disorder. It can be classified into squamous type and non-squamous type. Squamous type also divided into mild dysplasia, moderate dysplasia, severe dysplasia, or carcinoma in situ. And non-squamous اللي هو نسميه الباجت disease. Regarding malignant tumor of the vulva, it is rare and account for 6% of gynecological malignancy and 1% of all cancer in women. Most vulval cancer can occur after the menopause and associated with high-risk human papillomavirus infection. Risk factor and etiology of vulval malignancy is lichen sclerosis, if present, associated with 4 to 7% risk of developing vulval cancer, vulval intraepithelial neoplasia, Paget disease, immune suppression, melanoma in situ, high-risk human papilloma virus infection, smoking, advanced age, history of cervical neoplasia, or a risk factor for the etiology of vulval cancer. Regarding clinical symptoms, majority of symptoms are painless bleeding unrelated to menstrual cycle, appearing of vulval skin white-eyed rough patches, pruritus, ulceration, pain, and discharge might be associated as a clinical symptom, involvement of the vagina and the urethra, tenderness and discomfort, and growing lymphadenopathy. This picture shows the commonest sites of vulval malignancy. Regarding the investigation, biopsy, of course, it's for the tumor, and histopathological examination, Also MRI, CT scan, ultrasound to assess lymph node involvement. Histologically, majority are squamous in 90% of cases and 10% are non-squamous in type. اللي موجودة non-squamous هي بالبارثولين gland cancer and malignant melanoma. Spread, first spread is by local spread. Second route of spread is lymphatic through superficial inguinal lymph node and deep inguinal femoral lymph node. And the last modality or route of spread is hematological, which is uncommon, more if the tumor is large and already involving the lymph node. Staging, surgico-pathological, stage 1 confined to the vulva and or the perineum, stage 2 confined to the vulva and or to the perineum but more than 2 cm, stage 3 extend beyond the vulvovaginal and lower urethra or anus with unilateral regional lymph node involvement. stage 4 تتقسم إلى 4A and 4B. 4A involves the mucosa of the rectum or bladder and urethra with bilateral metastasis. Stage 4B, any distant metastasis including pelvic lymph node. The prognostic factor, the 5-year survival with no lymph node involvement is in excess of 80%, falling to less than 50% if inguinal lymph node involved, and 10 to 15% if iliac lymph node involved. Second prognostic factor is the site of the tumor. The central tumor located close to the midline, يعني nearby the clitoris, urethra, or the vagina, or the anus, having high risk of bilateral inguinal lymph node spread than tumors located to the lateral side. The central have bad prognosis. The tumor size, the larger the tumor size, more than 2 cm, the bad the prognosis. Depth of invasion, the invasion of more than 1 millimeter with more risk of spread to the lymph node. And last prognostic factor is the lymphatovascular space involvement. Treatment in cases of microinvasion, a wide local excision may be all that is required. But in other advanced cases, for a tumor larger than 2 cm or deeply growing into the underlying inguinal region, we have to do radical removal of the affected vulva with wide margin, and complete removal of the growing node is necessary. But the drawback of this surgery is the wound breakdown. Although radiotherapy is not used as a primary treatment for vulval cancer, it is used for management of patients with positive growing node and can reduce their size after primary surgery. This picture shows partial vulvectomy, and the second picture is showing the radical vulvectomy. شوفوا wide area of incision that might associated with wound infection and breakdown. حاولت أختصر لكم المحاضرة وأريدكم تأخذون هذا المختصر المفيد. إذا أريد أسألكم بالامتحان من هالنقاط. شكرا جزيلا.